Thank you for being here. I'm Bill Green, CEO of Homestead Smart Health Plans. And I have the pleasure of introducing Governor Ed Rendell, who I first met when I was 11 years old on a street on Green Hill Road outside my Aunt and Uncle Tim's house, where they were having a fundraiser for him when he was first running for District Attorney of Philadelphia. I met Ed many times after that. For those of you that know Ed Rendell, you will be maybe surprised to learn that most of the time as a high schooler it was at a Dunkin' Donuts on Midvale Avenue while he was district attorney and I was sneaking out of class to get some chocolate donuts. He was always engaging from the time I was 11 to the time I was in high school, asked me about myself, treated me like a real person, seemed genuinely interested in me. Not my father, not my mother, other people, but talked to me. So when Ed ran for mayor in 1991, I took a semester off from college. I came and joined his campaign as a volunteer, and I wrote policy papers for Ed. And I've been very pleased so I get to thank Ed Rendell for doing what he did for the city of Philadelphia, for the Commonwealth of Pennsylvania. But for me, it's very personal because I've never had the chance to thank him publicly for the support he gave me when I first ran for city council in 2007, and for the kindness he showed me throughout my life from the time I was 11 years old. So thank you very much, Governor. Governor Ed Rendell.
Good morning, everyone. Thanks, Bill. Bill has fulfilled that confidence I showed in him. He was a great city councilman and stepped down from one facet of public life to help education. And the School Reform Commission did some very good things for education, which they didn't get credit for, and Bill was a driver of many of those things. I am real pleased to be here today to kick this off because healthcare costs and quality and accessibility have been an issue for me from the time I was mayor, particularly during my 8 years as governor. And even now as a private citizen, I continue to advocate for new ways of doing things in the healthcare delivery system. Our healthcare delivery system is obviously broken. We spend more money per capita on healthcare than any country in the world, and our outcomes rank us not even close to the top 10 in terms of overall health of our citizens. We have, for the richest country in the world, to have as many uninsured people as we have is a flat-out disgrace. For some people, contracting cancer is a death sentence, a flat-out disgrace. Your health care depends, and your health and your lifespan depends more on your zip code than anything else, a flat-out disgrace. So we've got to find ways to do things better, and that means reducing the costs of health care at the same time improving accessibility and the quality of health care. That seems like a big jump, but it's possible. I believe it is possible, and I believe we're here today to discuss some new and exciting initiatives which I think will help us reach those goals. I've known Homestead's founder and chairman, Tom Knox. I've known Tom since I ran for DA, and Tom was with me when I was mayor and headed up the Office of Management and Productivity, and also gave me advice during the time I was governor. And there is no one in Philadelphia who knows more about health care, who knows more about how government and the private sector can save money than Tom Knox. You're going to hear a lot about Tom's latest vehicle called reference-based pricing. Bill's going to explain it to you in a little bit. But reference-based pricing is already adopted by Montana and North Carolina for its own health plans. And North Carolina is projecting a 15% savings with no diminution in quality and increased accessibility. 15%. The state of Pennsylvania could save 15% on its health care, and not just for its employees, but for prisoners, for a number of people that the state does under the Medicaid program. If we could cut our costs by 15%, it would be just a manna from heaven. And I've tried to connect Tom Knox with the people in Harrisburg, and we're working on it. But reference-based pricing is an exciting concept.
Governor Rendell talked a little bit about what we do, but I'm excited to tell you more. Healthcare economics is an oxymoron. Essentially, regular economic principles don't apply when it comes to healthcare, a $1 trillion segment of the U.S. economy. The payer is not the person who is choosing to get the service. That's a large part of the problem. There's also incentives over regulation. I'll talk about the minimum loss ratio and the perverse incentives created for the major carriers. And then also hospital systems have basically inflated list prices that are arbitrary, bear no relation to the provider's cost at all, or a fair profit. So that's called the charge master. I'll get into that in a second. So there's a great video that will explain this, which we're not going to run today for the sake of time, but it is called, if you just Google Adam Ruins Everything Healthcare, it explains a lot about the pricing mechanisms in hospitals. So here's the problem. Increasing healthcare costs year over year. This results in cost shifting, so employers have increasing healthcare costs. They try to reduce that cost year after year by having the increasing deductibles and coinsurance for their employees. So right now the situation every year upon renewal is lose-lose. The employers pay more and the employees pay more. We are working to change that. So I talked about the charge master. Essentially, they're exorbitant. They're 400 to 700, sometimes 1,400% of Medicare. 1 to 3% of patients actually pay them. And charge master prices drive up the cost of healthcare for everyone, including the insured. There's a professor at Lehigh University who teaches law and business named George Nation, who's written a bunch of great articles on this topic. Also, we all know hospital costs are rising much higher than inflation. They were 72% of Medicare in 91, 2011, 343%, and today they're 450, 500% on average across the country. Also, you can have a $7,000 procedure at one hospital in town, and that procedure is going to cost $60,000 at another hospital in town. Here's an example of joint replacement pricing across the country. What is missing? What is missing is transparent pricing, and we'll get into that in a few minutes. So when I talked about incentives and overregulation, one of the unintended consequences of the ACA is something called the minimum loss ratio. That says that the major carriers must pay 80 to 85% of their premium dollars to healthcare providers. It makes sense in that I'm sure Congress and the President were thinking, well, if you have to spend it on premium dollars, then you're going to have the most efficient healthcare possible. The problem is that once you've taken that 15 or 20%, reduced your administrative costs as much as possible, your profit is the balance. So the only way to increase profits quarter over quarter and year over year is to increase the amount you pay for healthcare every single year. And that's why most public companies that are health insurers stock is up 1,000% in the last 10 years. So there's a perverse incentive in the marketplace. So in other words, if an insurer could pay $8,000 for a procedure instead of $10,000 for a procedure, or for many procedures, to use that negotiating power would cause them to have to give money back to their fully insured members, which you may have read some insurers had to do this year because they didn't get it quite right. So also interesting, for CFOs, as we go around talking to them across the city, we ask them what their first largest cost is. Obviously payroll, usually. Their second largest cost is usually healthcare benefits. And I say to them, well, what other expense do you have like that where you haven't negotiated your prices directly with the person you're purchasing the services from? And there's nothing else in their business where they allow that to happen. But instead, they allow these intermediaries called insurance companies, health insurance companies, to negotiate prices across the country, and this is a result. So those companies are negotiating prices that benefit them, not necessarily self-insured or employer groups, or even they're fully insured. So here's an example of an MRI. If you walked in off the street, it would be $938. The insurance cost was $5,265, and patient responsibility is $2,756. There's an office procedure, $580 versus $1,850, with the insured having to pay $1,850. So there's lots of articles about this. This is just one person, Gene Pinder, and Clear Health Costs did a study of this kind of situation. So, so what do the insurance carriers offer? They don't improve quality. They don't reduce cost. So what do they advertise? They advertise access. You'll see the phrase around town, most doctors. But that doesn't improve outcomes. So what we do to solve this problem is called reference-based pricing. So we pay providers directly on behalf of employers, cutting out the major carrier middleman. We use a reimbursement technology or reimbursement methodology that is clear and transparent. So that means we pay a percentage, we pay Medicare plus a fair markup, or we pay the hospital's actual cost as reported to CMS, the Center for Medicaid and Medicare Services, plus a fair markup, whichever is greater. And I'll get into that. So we don't work from a top-down approach, charge master at 700% of Medicare. We look at government data to determine what is a fair reimbursement to the provider for the cost. So we take a bottom-up approach that increases transparency, because we're all across the country have a baseline. We know what Medicare is. We know what the hospital's actual cost for the service is, because they're required to report it to the government. This leads to lower unit cost, which is attractive to both employers and employees. And it allows us to fire traditional carriers and do the things that will change healthcare in a transformational way, because lowering unit cost alone will not do that. If you lower the unit cost, that doesn't improve outcomes, as Neil and Roy were focused on. And providers will adjust. As Neil pointed out, with these 35% unnecessary procedures, they'll adjust by providing more services per visit in order to make sure their revenue stays the same. So what's reference-based pricing about? Yes, lower unit cost right now, but it's really about firing the carrier. And so this is what reference-based pricing allows: disruptive innovation. And Roy talked about that in terms of direct contracting between employers and employees. And so we have a contract with Penn Medicine, and employers can access that, paying us no fee. They get our direct pricing with Penn Medicine. This allows for shared risk, warranty, as Roy discussed, bundled payments, direct primary care. So the company doctor is coming back in the next 5 or 10 years, where employees are going to be told, this is your primary care physician, this is where you go. If you go there, you have no deductible, no co-insurance. That person is going to direct your care with specialists, with hospitals and providers. True disease management. So by that I mean the insurers will say that they have disease management, but they have a disincentive to reduce the amount that they are paying to providers. So it is not very effective. Mandatory second opinions, which you can't have with most insurance plans, and opioid prevention and other innovations. And that is the true power of a reference-based pricing approach. So direct contracting, I've discussed this, and the key here, I think, the key takeaway here is that this approach will improve outcomes for employees, keep people in work more, increase the productivity of your workforce, save you money, and save your employees money. So we have one employee who has a slice offering, which means half their employees are on a major carrier and half their employees are on our reference-based pricing plan. The employer saved 20 to 25% on their cost, but the employee because we're reimbursing at a fair and the fair price, and that there's a lower employee contribution because our plan costs less to the employer, actually saved $1,800. So this creates a true win-win where the employers no longer have to shift increasing costs over to employees. We're very proud of our contract with Penn Medicine. Let's see where we are here. Okay, so this is why we pay the greater of cost or Medicare. If you look at items 2 and 6 on this chart, next slide, item 2, the actual cost plus 20%, as an example, would be $21,000. It would be unfair to pay the provider Medicare plus 25 because their cost is far less at $7,150. Most people who say they do reference-based pricing in the market today only pay Medicare plus, not Medicare or cost to charge, whichever is greater. So we believe this methodology is fairest to providers and to employers. So here's a couple of case studies I'll go through real quick. You can see the information up there. We replaced a major carrier at a company with 250 employees in Montgomery County. They're a food processor. This was an 8-month figure. They saved 36%. The full year is now in, and they saved 55%. They have $1 million in their claim fund at the end of the year, which is significant for a company of this size, and don't have to contribute to healthcare again until that $1 million is spent down. The next company is a manufacturer in the middle of PA, the last surviving subsidiary of Bethlehem Steel. They were having trouble with foreign competition. They needed to save money. If you look at this, they have negative trend. They were spending $1,271 4 years ago. They spent $921 per employee. No change in plan design, exactly the same plan design. In this case, we have true medical management with one of our partners, HCS, out of Columbia, Maryland. There is direct primary care contract for the employees, and there is a direct contract with a local hospital system. Also, we have a fully transparent PBM and RX. Savings can be significant when you combine all those things together, which is why we're excited about our contract with Penn Medicine and what it will enable. So, bottom line, with us, there's no network, although we'll drive you to people we have contracts with, like Penn, with no deductibles and no co-insurance, and having them exist outside of that market relationship. The one thing you'll hear about reference-based pricing plans is what if a provider doesn't accept it? Employees can occasionally get balance billed. It is a little bit more work for employers, but you're truly transforming the relationship your employees have with healthcare providers. They're going to be healthier, have better outcomes, spend less money, and so will you. So traditional plans provide absolutely no protection against balance bills. About 2 to 4% of people go out of network on traditional carrier plans. And the employer, they get their $20,000 bill, they have 40% co-insurance for out of network, the employee has to pay $8,000, the employer does nothing for them. Under our plans, it's about the same percentage, 2 to 4%, end up with a balanced bill. And the difference is our company provides a full legal defense for that member, and they never go out of pocket. So thank you very much. That explains us. I'm going to introduce Tom Grant.